and just writing things down, like you said, to be able to kind of observe it in the brain. So a
Yes.
combination of all of it, it helped, and just writing things down over and over, doing flashcards, and
Mm-hmm.
just following everything you're teaching us, and pretty
Okay.
much everything is there.
So I'm going to ask a question. You don't have to answer. What was your score on diagnostic test 1, 2, and 3?
The diagnostic 2 was like 76 point something, and then
Okay.
the diagnostic 3 was 78.87, and then I took it a week later and it went up to 94.
Okay.
So, yeah, and then my first one was really bad. It was like 50 something.
Yes.
So,
Yes.
I mean, I improved through the whole time, and I just kept reading and writing and memorizing things, and it just kind of all came together at the
Yeah.
end.
So, the reason why we ask people to take the diagnostic test 1 right in the beginning is because some people think, oh, this is going to be easy. This test is nothing. You are in for a shock. This test is hard.
Yes.
We have
Yes.
nurse practitioners, family nurse practitioners that have been practicing for 20 years that they can't pass. Okay?
Yeah. No.
This is not a joke. If you are
Mhm.
not taking this seriously, you are risking your future. You really are.
That's right.
And
That's
that's why
right.
when you take it the first time, you realize that, hey, I'm not as bad as I thought it was, or I need to catch up. So it's an eye-opening experience.
For
And this is
sure.
what
For sure.
what we want to see is about 80, 79, 78 at the end, so which you are right there, which give you about a 95% certainties that you will pass. I can count in the palm of my hands from all 3,000 students that have scored 80 on the diagnostic tests once they finish the course the first time, and they did not pass. Very, very rare. Very, very rare. If you're scoring an 80, I'm telling you right now, you will pass this test. You are well prepared. Now,
is there a lot of medications in there, please?
Yeah, there will be lots of medication. There'll be everything that we teach you guys will be there. If you are not,
pretty much so.
If you're not
Pretty
consuming,
much, okay.
if you're not consuming our stuff, if you're just going through it like you're going through a regular book, you are missing out. You are missing out because there is no fillers in our course. I know it's still a lot, but I'm preparing you for anything that comes in a test.
That's right, because I had everything on the test, but they give you a little bit of everything, so you kind of have to study everything so that you're ready for whatever questions they're gonna ask. There were some questions in there that I had no idea what they're asking me, but I just remember, 20, like you said, 25 of those questions I'm not gonna count, so I flagged it and I went on. And then I just went back to the ones that I flagged that I didn't know and just answered the best I could. And and I did it. Thank you so much, and good luck to everybody.
All right, Olga. Nice.
Tonight.
Thanks for stopping by and encouraging other students. Have a good day.
You too. Bye-bye.
Bye-bye. That's awesome. All right, another one in the book. I swear from yesterday to today, we had probably about 10 students that passed the board. I got lots of emails this morning. If you still are in a race, right? We just finished modules 1, 2, and 3. According to the blueprint, will be 107 questions from domains 1, 2, and 3. So what does it tell you? That's where you need to spend your focus, guys. This weekend I'll be sending you, if you are in the course, of course, I'll be sending you a email with all the therapies, and I'll be writing down 3 to 4 things for each one of them. So when you look at it, your job is to memorize 3 to 4 things, and you should be good. You should get those 17 questions with easy. It's going to take me a little bit of time. I couldn't do it, from Monday to now, it's really hard for me. But as Friday starts to wind down a little bit, I will sit down in the computer and develop this email for you guys. And after that, I'll put it under module 4, our therapy course, and related theories, so you guys can have it, okay? But every single day, try to study for an hour or 2. It will come together, I promise you.
Dr. Lopez.
Hi.
Hi, good evening, sir.
Good evening.
Good evening, everyone.
Hi.
Oh, Dr. Lopez, I took the I took the exam today. Dr. Lopez.
Tell me good news. Tell me good news.
I was telling you yesterday that yesterday was Thursday. I want to join the Kahoot.
I know. That's why I'm worried. Now I'm worried. You didn't even know it was Thursday yesterday. So did you pass or not? Tell me.
Passed. Oh, God did it. God, this
Amen.
is not an easy exam.
It's not.
As you said, it's tough. It's hard. I've never seen an exam like this.
I'm telling you,
It's
but
very hard. Critical thinking.
critical thinking.
Everything is there. That is critical thinking.
Yeah.
If you don't know the content, you will not be able to think very well and answer those questions.
Yeah.
It's very hard. But God did it.
Amen.
God did it. Everybody, if you don't know how to pray, and study.
And study, okay.
Yes,
and study, okay.
It's not only pray, you have to study, because I did study, even though I wasn't coming to the class because I work night shift, but I made sure that I went through all the PDF. I went through all the questions. I tried to answer those questions, even though I wasn't hearing from Dr. Lopez to say if I'm doing well or not, but I'm seeing my grade. But the other ones, to say, oh, you do well or you not do well. I wasn't in the WhatsApp. I wasn't coming to class, but within me, I'm still studying and then trying my best. So with prayers and study, God will see everybody through. If I could pass this exam, nobody will fail this exam if I could. So what am I saying? Continue to trust God and believe Him and study, and God will do the best for us.
Yes,
Thank
absolutely.
you all.
Yeah, so that is another reason you don't have to be on the live class. Everything you need is right there in the program.
Yes.
Now you're gonna have to dedicate time. There is no easy pass. There is no magic bullet. There is no secret. It is hard work, and that's what you want it to be. Because if it was easy, anybody could do it, and that would not be a job for us, right? It is tough. It is tough, and it requires critical thinking. Well, now, if you need something from us, just let us know as you get your first job, and then if you need support, we'll be here.
I need support. I will need support. I would like to join the whatever support group, please.
Yeah. Send me
I need the WhatsApp or whatever you guys join it.
You gotta send me an email, okay?
I have sent email several times. I didn't get any response.
I don't know about that. Make sure you got the right email. I promise you.
Okay. I will send another one.
Please do.
Okay. Thank you so much.
Thank you. Bye-bye.
Bye.
All right, folks. So we're about to get started. So I trust that everybody knows how to log in, right? I ask you guys to come in a little early. We are about to get started. So let's give it 4 more minutes of grace period. If you have not logged in, this is your time, guys. Get your camera. There is a QR code here. We'll be starting sharp 7:10. Okay. Well, actually a little bit early, 2 minutes from now. Okay, 7:08 to be getting started. Go ahead, Ramondo.
Okay. Yes, I have it on my phone. So how would I type my answer?
Okay, so once the question shows up, you gotta press one of the colors on your phone. Great question. So you answer Kahoot on your phone. So this is an interactive game. Okay, so you use your phone to answer the question. You will have 1 minute per question. That's it. So this is on purpose. On the task, if you divided the amount of questions, it will be 1 minute and 20 seconds. So now we are going to be a little bit lower than that to help you make those 175 questions on time. Okay. All right, folks, we're about to get started right now. Good luck, everyone. And let's do this. So we have about 96, 97, 98, 97, 100 folks. So that means it's a lot of people, right? That means if you're scoring the top 20, you really are well prepared. Remember, there will be 33 questions on this module. You really need to know the PDF. You really need to know the PDF for modules 1, 2, and 3 really well. Do not skip it. Do not leave any chance, only a positive experience, okay? Good luck. Let's get started now. You respond to the questions on your phone. Okay, so this is the typical question in which you read the book and you probably would have picked lithium, right? Because the lithium is the gold standard therapy. Guess what? Lithium has a narrow therapeutic window. That means you cannot mess that up. It's 0.6 to 1.2. What happened is that you have to titrate slowly, right? Titrate slowly. Are you going to stay with this patient for 2 weeks in a hospital? Manic? No. So we started with an SGA and then transition to lithium, right? So a good option, it is olanzapine, right? It's just an initial option to get the patient mania under control. And then you switch to a mood stabilizer, or you could have the upper and lower, meaning a mood stabilizer will be controlling the lower, like lamictal, and you could use for upper Geodon, Abilify, quetiapine would be excellent choice, right? Here's the golden nugget, right? So basically, when you have someone needing a fast stabilization of mania, antipsychotic could be a good choice. Okay, it could be a good choice. Lithium is the gold standard, but it has a narrow therapeutic window, which requires careful titration to prevent toxicity. Okay. Let's see if we have a quick questions here, or if not, okay, nope. All right, so seems everyone got it. So it's very tricky. So you only would know things like this whether you've been an experienced provider, or someone told you this in clinical, or you've been in a course, right? Because the book goes, lithium, it is the gold standard for mania. Yes, but in practice, you do not start with lithium, because unless if you want to keep the patient for 2 weeks or so, right? Okay, next question. Folks, in order to play, it's always best to arrive early. Oops, sorry. Okay. So yesterday we talked about tolerance, right? What is tolerance? And we said, hey, there are other definitions that you need to know. So everyone got it. So let's take a look. 100%. So that's awesome. 109 people got it right. So that is not too challenging, right? But do you know the difference between, you know what kindling is, right? It's like the brain remembering the previous seizures. So now it gets overexcited when one is about to happen again. You need to know the definition of addiction and potency, right? So knowing withdrawal is important. We got a tolerance. Knowing withdrawal is important, right? Specifically for alcohol. Oftentimes people will mix withdrawal with maintenance medication, right? Uh, a compensate, naltrexone, right? Those are maintenance medication. Dependency, you need to know the definition of dependency, right? Is when the body needs the substance to function normally to avoid the withdrawal. Okay. And addiction is doing whatever it takes to get the drug in despite of harmful consequence. You need to know those because they often come in the same question because they are related terms. Okay. Okay, we got 10 seconds. Everyone almost answered. All right. Okay, so we got ADHD as the answer. Conduct disorder. It was two people pick conduct disorder and two folks picked autism, right? The best answer is ADHD, right? So, guys, you get points from getting the right answer and you get points from being fast. Okay. So if two people get the right answer, the one that answer faster gets more points. So be on a watch out for them. You need to differentiate ADHD types, right? Uh, impulsivity and hyperactivity, inattention, and combined. Yesterday, we went over the symptoms of each one of those, and it's important that you know. Okay. Now, when you talk about ADHD, right, inattention, hyperactivity, impulsivity, or both, these are the three types that we talked about. It really affects the individual ability to focus and their impulse control, right? When assessing for ADHD, very important. It needs to be in two locations. It cannot just be at home or at grandma's house. This is why we give the Vanderbilt to the teacher, to the mom, to the sister, to the dad, and we compare, right? If the patient develops a tic disorder, I don't care how well the ADHD medication stimulant is working. You stop the stimulant, right? Non-pharmacological treatments can be behavior therapy, psychoeducation, and family therapy, very helpful. Okay, we got 5 seconds. Pick your best answer and go. Yes, it makes sense, doesn't it? We have a hypoactivity of the prefrontal cortex. No wonder they can't they have difficulties with harder tasks. They can't find their keys or anything that's challenging. They have more difficulty. But what else happens with ADHD? What other brain parts are involved with ADHD? Right? It's not only the prefrontal cortex. We have the basal ganglia, and we also have the 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 reticular activating system in general, right? If we go back to the frontal cortex, pay attention. I need you guys to take a picture of this. The dorsolateral, right, of the frontal cortex is important for you to know. That is the inattention. Impairment in this area is linked to inattention. The anterior cingulate is a part of the limbic system. That is, has to do with impulse control. These are two definitions you need to know. Anterior cingulate and dorsolateral prefrontal cortex. And sure, the basal ganglia is your modem, your fidgeting all over the place. The reticular activating system is the ability to focus, fight or flight, sleep, arousal. Now you put the whole together picture of what one with ADHD looks like, and you know exactly which brain portion is being under performing. Okay, please know dorsolateral, please know anterior cingulate, and what do they do? These are very high yield information. Now I cannot show the previous slide. Once it's gone, I cannot come back. Okay, we got 15 seconds. Okay, great question, right? A good question will divide everybody here, right? Now, I just mentioned on the first slide, and please correct me if I'm wrong, if someone is taking a stimulant and develop a tic disorder, a modem disorder, a vocal tic, you stop the stimulant. So in that case, I'm not sure if I was not very clear. You cannot give methylphenidate and you cannot give Vyvanse. And if you were giving that medication, you need to stop. Okay. Now I want to call attention for why not Strattera, right? Strattera is a medication that's approved for ADHD, right? Why guanfacine over Strattera, right? Go ahead, Marquita, I'm sorry.
I'm just confused because I had a question like this and I picked guanfacine and they told me it was wrong and the answer was Strattera.
We have to look at that question, so I don't know. We have to look at, sometimes it's not exactly as you recall. We'll have to look. If you can send it to me via email, we'll look at it. So the choice here, two possible choices, Strattera or clonidine. So clonidine, right? And guanfacine are the best option for those with tic disorder. Okay, so that means we could also use guanfacine or clonidine for Tourette's, right? Because they treat moderate tics disorder and also help those with ADHD. Strattera would only help those with ADHD, but not necessarily help with tic disorder. For that reason, it is the best choice. Guanfacine or clonidine, non-stimulants, FDA approved. Okay. Now, if you think, we'll go back to the age. We have more questions on that. So we'll talk about age, when to prescribe to all age in a minute. So we revised this from yesterday. All right. Okay, so one quick second here. I think the question was not, it says psychoeducation is important. It's the first step for ADHD management, right? So not that behavior therapy is not a good choice. I think the question was a little off, and that's why some people pick behavior therapy, okay? But psychoeducation, it is the first option when teaching parents about ADHD. Okay, so I do apologize that. Now, what I wanted to call attention is for this question is that all questions on the board is all about the patient. It's almost never about the family. With ADHD is a little different, right? Because if you are a mom or a dad and you don't have medical knowledge and someone says your child has ADHD, you can see, you can see them in distress. So what do? You stop. At that point, you do not continue the education. You address the parents. So you provide brief supportive therapy if they become distressed during the ADHD diagnosis. Okay, so that is the main point that I wanted you to bring up for this question here. It wasn't well written, so I do apologize on that one. Okay, Nikish, go ahead. Got a question there?
Yeah, but also, isn't it also true that you can use the age, because based on the age of the child, an 8-year-old doing a psychotherapy will not understand what it means and its implication as well, isn't it?
Yeah, it's a valid point for sure. It's a valid point. Thank you. All right, so let's get to the next question, but it is true. All right, pick your answer kind of fast. Everybody should get 100% on this one, right? 3 seconds and go. Okay, almost 100%. Please do not send your borderline patients to the ECT, okay? Not necessarily. Okay, it's not necessary. All right, and antipsychotics could be, but not the first option, all right? Could be. I'm not saying that it's not possible. It depends how aggravated they are, but definitely not the first choice, okay? All right, so DBT is the gold standard, right? You need to know DBT is for borderline, right? ECT, we are going to send to those that are catatonic, or maybe schizophrenia, or depression that has been resistant to medication. Yesterday, we talked about the signs and symptoms that we need to know about ECT, right? After they have gone through the ECT, when they lose recent memories, right? Now, I wanted to call attention for a few things here. When you hear DBT, you gotta remember Marshall Langham. DBT is the gold standard for borderline patients. What is the goal of DBT is high yield? Is to decrease crisis generating behavior and helps the patient make decision making and communication, right? Other things that can be helpful, mindfulness, distress tolerance, emotional regulation, interpersonal effectiveness. That all comes together with DBT. Very, very high yield. Please take a picture or write it down. It is helpful to do diary keeping for DBT. For borderline personality disorder, to make the diagnosis, diary keeping. And lastly, but not the least important, is emotional object permanency and object constancy. That if you go back to Piaget, our modules on Piaget, when the mom goes away and the baby goes into distress, that reminds you of what? Borderline patients, when the therapy goes away, the therapist goes away, they go into distress. They struggle with emotional object permanency. In people with borderline personality disorder can be the hallmark symptoms of this disorder, right? So please don't leave me. That's what I say, right? They cannot be together with their partner, but they cannot be apart, right? So Marshall Langham, gold standards, DBT. Why DBT is important? Decrease crisis generating behavior, helps with the decision making, communication. Diary and keeping is important for borderline personality disorder. And remember, sensory motor Piaget is the stage that they have not mastered. Well, Dr. Lopes, isn't that from 0 to 2 years old? Yes, but age does not matter for Piaget. It matters for Erickson, stage of development, but not Piaget. Very high yield. We're going to cover all this on Module 4 next week. Okay, we got 15 seconds left. Pick your best answer. Okay, narcissistic, the best thing ever since sliced of bread, right? The company or the workplace cannot exist without them, or so they think. They want the accolades, but they do not want to do the work, right? Major depressive disorder characterized by persistent low mood, right? Changes in sleep, appetite, energy level. Bipolar, we talked about bipolar 1 and bipolar 2, the difference yesterday in detail. And we talked about OCD. Remember that we have to separate OCD, the obsessions and the compulsion. What are they? If we don't know what they are, we could get in trouble for the test. And we also said when you see tics, that could be a compulsion driven by the obsession. Obsession comes first, and then there is the compulsion. For example, the obsession would be thinking about microbes. How are we going to clear that? Is with the compulsion, which is the hand washing, right? So when you see a tic disorder, do not think it's Tourette's immediately. Read the question carefully. Okay. Now, narcissists are characterized by extreme sense of self-importance, right? Envy of others, and oftentimes they really exploit others. They may show a strong sense of entitlement, like I need this or I'm entitled to this, and they have a lack of empathy. Oftentimes, narcissistic and antisocial personality disorder, they share a lot of traits, right? But the problem, not the problem, but antisocial personality disorder is associated with reckless behaviors, right? They don't care about the rules at all. They have lack of remorse. And remember, if we are talking about a personality disorder, look at that age. They should be 18 and over for test purpose. Okay. You guys are fast. We got 115 answers. We got 15 seconds left. All right. 5 seconds. 120 answers in. Okay. Almost 100%. I trust that those folks got a fast finger there, right? And they picked the wrong button. Diane. Hi, Diane.
Hi, Dr. Lopez. I just had a quick question about the difference between schizotypal and schizoid. Can you please just clarify that?
Okay, before I do that, which I will, what do you know about schizotypal?
I think schizotypal, they want to be like everybody else. So they try to, they do stuff, but they are kind of shy. They are kind of closed off. But with the schizoid, they don't even care.
Good, good. So yeah, I think you're almost there. Can anybody else improve that answer? But you're very close. Okay. So somebody said schizoid, they avoid. Anybody else wanted to give the difference between schizoid and schizotypal?
Schizotypal, they are odd, eccentric, and they have ideas of reference. While schizoid, they lack social relationship, like they don't want to be in relationship, like emotional. They don't have emotions, kind of like they don't want to be in like relationships.
Okay, perfect. So schizotypal is the odd kid. He is in a basement and he has this magical thinking, right? And he really want to socialize, but he's too afraid because he's too odd. He has this magical thinking, ideas of reference, eccentric beliefs. Now, your schizoid, he is indifferent to what you think of him. He doesn't want a girlfriend. He doesn't want a boyfriend. He doesn't want a friend. He's just fine being alone. Whether he does a good job or a poor job, he's indifferent. He doesn't care. Not that he doesn't care, he's just indifferent. You know what I'm saying? So it's important that you know schizotypal and schizoid really well. They both belong to cluster A personality disorder, along with paranoid personality disorder, right? Key feature is magical thinking for schizotypal and unusual perception experience, right? People with this disorder have a discomfort with close relationship because of their oddness, not because they don't want to necessarily, maybe they also don't want to, but they feel too odd to be close to somebody, right? Unlike schizophrenia, schizotypal personality disorder does not involve psychosis, true psychosis, right? Such as persistent hallucinations and illusions, although they may have unusual perceptual experience. So hopefully that helps. But if you still are confused, you need to write it down, schizotypal and schizoid, because these are high yield types of personality that we must know for the test.
Dr. Lopez?
I was gonna go ahead.
Can I just add to that? I think of when I think of schizotypal or typhoid, I think of Doc Brown from Back to the Future.
Oh, okay. That's good.
And Dr. Lopez, for the schizotypal, another way that helps me remember for the T, I think of tinfoil. Like they're in the basement wearing a tinfoil hat. So, just a bit off,
Yeah, that's good. Yes. Okay. So very important that you do not confuse obsession compulsive personality disorder with OCD. Okay. And antisocial, they want to take your money, they are lawless, right? That is not what it was being described. So if you are having trouble with personality disorder, you need to know those very, very well, right? We talked about borderline personality. This is not what described today. And we talked about histrionic yesterday. They want to cause attentions for themselves. They just want to be seen. So please know personality disorders, okay? So think of a obsessive compulsive personality disorder, one that writes paper, and the deadline is today, and they want it to be so perfect that they rather not turn it in the paper because of they want it to be so perfect, right? So that causes a lot of distress. Nothing in life can be that perfect, right? So they'll hold off, and never really turn it in. Or one that's really secure with money, never spends money always, even though they have money is not a problem, but they're so stingy, so want to have hold of the of the finances, even though they're well off, right? Do not confuse OCPD with OCD, right? When we're talking about OCD, think about obsessions, which is intrusive thoughts, usually before the repetitive behaviors, the compulsion. It's very important. We need to separate that, okay? That could easily be questions on what is obsession and what is compulsions. In contrast, people with obsession personality disorder, obsession compulsive disorder, personality disorder, their behavior, trying to be perfect, always order and control of the situation, right? Even in desirable part of their personality, right? Even sometimes they know they are being unreasonable. They still have difficulty with giving things away. Okay. So if anybody, once I pass it on the slide, I can't stop. It goes automatically. So here we go. Next slide. All right, everybody's too fast. I gotta make harder questions. Sorry about the misspelling there. Okay, 5 seconds. Pick your best answer. Okay, so everybody got it correctly. So I didn't see that hand. Stacy, do you have a question? Oh, Stella, do you have a question?
Hi, Dr. Lopez.
Hello.
I was actually going to say, please can my peers, when we are trying to read the question, I know some of you are expert in this field. Some of us are still learning. When there is a question up there, could you stop talking, please? We cannot comprehend, please. This is Kahoot. When there is a question up, please let us read.
They were finishing up their last, he was talking with that other person, so that's where they happened. So
Okay. All right. So yeah, once we pass the slide, I can't stop it. So, but when we think about autism spectrum disorder, right? They like the sameness. They like fixed interest behavior. Think of them as when called by their names, they don't answer, right? Unless if it's the father or the mother, they have problem with social reciprocity, right? Or the lack of interest in playing with others. So the parallel play with autism is prolonged. Every kid have a parallel play time where they play along but not with. But autistic kids usually, the parallel play is usually extended. Okay. So next question. It's going to be a hard question. Okay. Yes, I said it was going to be a hard questions because you can't do cognitive behavior therapy is not necessarily wrong, but the best really is applied behavior analysis or ABA therapy, right? That is the foundation for autism spectrum disorder, right? Is the commonly recommended and is highly effective non-pharmacologic intervention for children with autism spectrum disorder. CBT really it's an approach that focuses on identifying and modifying the maladaptive thoughts, patterns, and behavior. While CBT can be beneficial for individuals with various mental health conditions, including anxiety and depression, it's not typically the primarily intervention for addressing autism spectrum disorder. And definitely not ECT, guys, okay? Okay. Now, pharmacological management for autism spectrum disorder, antipsychotics can be a good option only if you are trying to address tantrum, aggressive behaviors, or self-injury. Okay? Think of the broken mirror neuron theory for autism spectrum disorder. That is important. Okay? Repetitive behaviors like hand flapping, and insistence on the sameness are also hallmark for autism spectrum disorder. Mood fluctuation. Okay, so hopefully mood fluctuation really gave it away, right? So when you think about disruptive mood dysregulation disorder, think in a sense someone with severe temper or irritability, right? Some might call it children with bipolar, for the lack of a better word, right? And it is a mood disorder. That means you have to give what kind of questionnaire? A mood questionnaire, right? It is part of depressive disorder, DMDD, characterized by persistent, long-lasting dysregulations of the mood. So please make sure on the test, whether it's bipolar, whether it's DMDD, you give a mood questionnaire. Usually those diagnoses are for those between 6 and 17, right? If they're 18, you probably would call them bipolar 1 or 2. Mood stabilizer can be used along with SSRIs medication. And because it's part of a bipolar family, again, family history would be high yield to screen, right? All right, 5 seconds. Pick your best answer and go. Okay. Um. Okay. I was wondering, what would be the rationale for bipolar disorder depressed phase, right? Um.
I hit
What?
the wrong answer.
Okay. Okay. That can happen. It's Kahoot. But if anybody else wants to give a different rationale, it would be kind of good to know. I hit it wrong as well. The same. We have three people that got it wrong by mistake. I trust that is the team, right? Because there was nothing in that question that really gave it away to be a bipolar disorder. So on the test, the answer is always what is most likely to diagnose, meaning that they will not give you 5 symptoms over 2 weeks to make it a true DSM-5 major depressive disorder, right? We're looking for the most likely diagnosis.
Hi, so I actually don't know how to select answers. I've been trying.
Okay, 1 second right there. Okay, we got 5 seconds. Okay, why do we give fluoxetine first rather than amitriptyline, bupropion? Bupropion could be a good choice too. Is because it's the least SSRIs are the safest in case of overdose, right? So you need to know that. Very important. Okay. So the person that asked, you have to be in the game in order to play, and you have to use the phone in order to select an answer. At this time, it will be difficult to put you in the game, but next time you're more than welcome to come a little bit early, and I can walk you through it on how to join the game. Okay.
Okay, thank you.
My pleasure. Hopefully everybody picked the right answer. All right, we want to give Zimbao the effects or type of answers, right? Not that amitriptyline wouldn't be a good option, for example, but would be preferred that you use serotonin norepinephrine reuptake inhibitors, right, for neuropathic pain. What else can you use? Gabapentin would be a good choice if you are trying to control pain.
What about Lyrica?
Say it again.
Lyrica? What about Lyrica?
Lyrica too. Gabapentin, pregabalin, absolutely. Okay. So next question. Yes. If you're trying to prescribe Wellbutrin, right? History of eating disorder would be something to be concerned with, right? And also history of seizures, TBI. TBI will be in disguise, right? Because if you have a traumatic brain injury, it could lead to seizures, right? So a perfect horrible combination is someone that stopped drinking, needs Wellbutrin for ADHD, and now having possible seizure, right? One is kindling a decrease of seizure threshold due to the alcohol withdrawal, and they also take Wellbutrin or even stimulants sometimes. Okay? Okay, well done. So I was hoping that no one would give it a higher dose of antidepressants. So that was a good thing, right? Um, okay. So yes, if someone has a plan or they're impending scalene suicidality, then hospitalization may be the best option for the patient, right? Okay, so it's a hard question, right? So it's asking for bipolar depressive, what would be the best medication of choice? So does lithium cover really well for bipolar depression? No, it covers the high, right? Uh, Depakote is also very good for the mania episode. But if you want to do a good coverage for the depressive episode, a antipsychotic like Latura, Giodon would be a good choice. Even Lamictal would be a good choice. Yes, Lamictal would be a great choice as well. Okay, and that's why I like to do both of them. I like to do a mood stabilizer and a antipsychotic for those patients that are really truly bipolar. As I mentioned, the guidelines that I use, I think is the most beautiful guideline It is called the CPG, the Canadian Clinical Guidelines for Bipolar Disorder. It really teaches you everything you need to know about bipolar as far as the medications, and it compares each medication with scientific backgrounds to the why they recommend. Okay, Kelly, do you have a question? Okay, we'll answer the
Can you
question.
hear me?
Not, I can't stop now, so hold your question, please. Okay, so here we have a patient with hyperthyroidism, right? So how do we know? Heat intolerant, and look at the TSH level was 0.1. We need to know we need to know the labs in order to know whether it's hyper or hypothyroidism, okay? So before we move on to the other question, Kelly, do you have a question?
Yes, sir.
Okay.
For the exam purposes, are we supposed to answer based on clinical practice or what the book says?
It is both. I can't tell you one or another. It really depends. It really depends. I can't say one thing or another, right? So they should merge at some point. Now, what is not going to ask you is the latest thing. What is going to ask you is the gold standard, what's been true and tried. So the older, for example, they may not have Austedo there. They may not have Ingrezza there for medication for tardive dyskinesia because those medications are newer medication. But again, there is no saying whether it's going to be there or not. But usually the gold standards that they will always ask you, for example, FDA warnings, they will always ask you that, right, for those medications. Huh? Right. Next question. Okay, so fatigue, weight gain, cold intolerance, that is all the picture for hypothyroidism, right? So we looked at the picture yesterday and we kind of saw the hyper being heat intolerant, hypo being cold intolerant, right? So you need to know those features because they can come handy on the test day, okay? All right. So one thing that they have to tell you for generalized anxiety disorder, or they should, they don't have to, right? But they should. It says 6 months, because otherwise it would be almost impossible to know whether it is a unspecified anxiety disorder, specified, or other types of anxiety disorder, for example, right? But characteristically, they will need 6 months of excessive worry to be generalized anxiety disorder. Okay. Now we need to know panic attack versus panic disorder. And yesterday we covered acute stress disorder versus PTSD. We covered adjustment disorders. We covered conversion disorder. These are all high yield topics, for the board. So hopefully after today or over this weekend, go back to the PDF and revisit those topics if you are having trouble. Sorry about the misspelling there, though. All right, I gotta talk to my folks that are doing this game. Yes, so knowing your panic attack versus your panic disorder, right? If it's one time, it's your panic attack. If it's a repeated panic attacks, becomes a panic disorder. Why is it important? Because how you treat it, it is different, right? While the panic attack you could treat with, for example, a benzodiazepine, you could treat with Atarax. When there's a panic disorder, usually a higher dose of SSRIs would be a good start medication. Or if not, a combination of several things, right? You're not necessarily easy to get a hold of. But one thing to be mindful for practice is that they will oftentimes need a higher dose than major depressive disorder or a anxiety disorder by itself. All right, we got 2 more questions to go. Okay, so hydroxyzine could be a good option, but I want to warn you, if you have someone taking a inhaler for asthma, be careful with no beta blockers. Okay. In fact, I prescribe hydroxyzine for the same condition today. I would prefer that over benzo just because of it's less, it would not be addictive compared to benzos, right? I mean, it could be addictive, but nowhere near at all as close as to a benzodiazepine, right? All right, so everyone should get this one right from yesterday's lectures. Okay, so yes, I'm glad to see this answer. Everyone got it right. So now we really know conversion disorder. So that's great job, everyone. Now let's see who got the podium this week. Drums. NP. There you go. You are. Dopamine. And first place is, all right, on good. Now, Janet Bug and Victory. So good job, everyone. You know, whether you were the first or the last is all a spectrum, right? So it depends where you are on your preparation. Maybe if today you are the last person, we all been there before, right? At some point, everyone's been there. Nobody just was born knowing everything. Over time, you should be looking yourself in the first 20 position on the spot. So good job, everyone, for being here, for trying, right? So now, as we progress to module 4, you have to do a hard pause and go back to three PDFs on modules 1, 2, and 3, and really solidify what you learned, because now we are going to get into a harder topic, right, which is therapy. This weekend, I'm going to send you an email to all of you guys that are in the course. I'm going to break down each of the therapies. So all you have to do is read the email and read it more than once, and then you will know if a question comes up. You will like, okay, I know this, this, and this. I'm going to break it down like magic for you. All you have to do is read it. That means if you really did really well on modules 1, 2, 3, and you will understand therapies in bulk, you pretty much already passed the test. And then we're going to break down module 5 and then crash course review. So the crash course review is going to be October 18th and 19th, 2 days, right? 8 hours each day. So a lot of content that we need to know to pass the board. Come prepared. And that is it for tonight. I'll stick around. I'll answer any questions that you may have. But if you don't